I think it touches base again on looking at the person and understanding that there's, a lived experience in people with pain, call them influencing factors. So that could be financial issues, that could be stress, that could be lifestyle behaviors, but it could also be positive expectations. Man, I love when somebody comes in and they're like, so-and-so said this come to you. I heard you're great. There's other people who are like, I think PT sucks. I'm only here because my physician told me to be here. Those influence the overall outcomes at some point.
Back to the show, Dr. Mark Shepard. Welcome back.
Happy to be here.
You're like the James Brown of AM. You're the hardest working man in show business.
Oh, man. No.
Do I remember reading this right? 3 presentations?
Well, I got 2 sessions and then I'm on a panel, so.
It's a lot.
It's not too bad. My wife will tell you that I like to talk, so it's easy for me.
Yeah. But talking like this, number one, people see the talk and not the work that went into it, and that's fine. But that's part of the show. Yeah. But it does take a lot of work. I'm the kind of guy who starts working on it as soon as I find out, and then I stop working on it until 4 or 5 days before I'm supposed to give it, and then it's a rapid fire. But I know procrastination is my superpower. So you're teaching across 3 very different but connected areas: lifestyle medicine, competency-based education, and hybrid learning. Is there a thread that ties all 3 of them together for you?
Yeah, I think it's, at the end of the day, it's patient care, at least the practice side of things. So pain, lifestyle medicine, orthopedic manual physical therapy stuff. That's kind of the thread that I see. And then the competency-based stuff is really just trying to figure out how to maybe look at things maybe a little bit different than how we've done them, and try to mold things to the learner a bit better, so that we can, kind of complement their skill set that they may bring into, the program, and then adapt their kind of speed of learning. Yeah.
We're all pretty different in how we learn. Pretty different.
Yeah, for sure.
Like a long time ago, I think even when I was in PT school, that whole visual or auditory learner was sort of tossed out.
Yeah.
Right? I mean, you would think the podcast guy would be auditory, but if I can't see it, I'm sort of checked out. So it's nobody's any one of those things.
Yeah.
So competency-based feels like being able to at least look at the fingerprint and knowing that learning one topic I might get very quickly, taught one way, and a different topic taught the same way, it's not going to land, and figuring out why that is.
Yeah, exactly.
Yeah. In your from evidence to application session, you're pushing lifestyle medicine into orthopedic manual physical therapy. What's the most pragmatic way for a manual therapist to start doing that Monday morning when someone goes back into clinic?
Yeah, I think the easiest way is just asking about sleep. It's something we do,
it's huge.
Normally. It's probably the place I kind of was welcomed into lifestyle medicine. I years ago, 10 years ago even, I was just like, who talks about that stuff? Get on the table, let me manip you, and then let's just do some exercise, right? And then I learned very quickly, when you start seeing patients and then you're asking about this anyway, the 24-hour behavior and sleep and how things are in the morning, and I just realized how common people were talking about sleep issues. And it wasn't just oh, I'm in pain and I can't sleep. It's just I'm not well rested. I don't feel, like I'm getting good sleep. And it just, as I learned more about pain, I realized the huge connection between the much more than I ever thought. And so, it was something I was already asking about. And so it's really easy just to ask people, how much are you getting as far as hours per day of sleep, because not everybody sleeps at night, right? With shift workers. And then, do you feel well rested? And those 2 questions alone will get you pretty far. And it just, you don't have to jump on it day one. I think a lot of people are like, oh my gosh, I have enough to worry about, right?
Sure.
Now you're telling me I have to worry about this, this, and this. Sleep is one of those things that people are probably wanting and willing to work on, especially those with persistent pain. So just invites a conversation. And we just got a paper accepted at JOSPT. It'll be open access, looking at how to address sleep behaviors in the orthopedic setting in people with MSK conditions. So we really tried to lay out a very pragmatic way of the person on Monday morning, what can I do? So hopefully that'll be coming out soon.
Is it easier now to maybe convince is a bad word. Maybe it's a good one. Is it easier now to convince a clinician to ask about something like sleep? And is it easier, or are patients more receptive There was that book by Matthew Walker?
Yep.
Like, it's sort of now popularized, right?
Yeah.
The thing was a New York Times bestseller, so it's not like you're coming out of left field. Is it a little easier to have those people ask and be receptive of being asked?
Totally. Like now, especially people who are more active, they're very much into the lifestyle space. And so I think that awareness is there. But I think even 10 years ago, if you were to ask somebody, just pull somebody from here and say, if you wanted to be better in your health, what do you have to do? Everybody will say, well, I got to sleep better, I got to manage my stress, and I got to eat better, and I have to move more. Everybody knows that. It's just how do we do it?
Right.
And what strategies? And we can coach people to do that. I think PTs are at the perfect place because we have the time, we have the knowledge behind movement, and sleep and nutrition affect movement. It's totally within our scope. And, as we take a biopsychosocial approach, these things contribute to the person's well-being, whether it be pain, movement, or any type of functioning and physical activity. So to me, people know it. It's just us broaching and starting conversations and then knowing how to deal with people who want to change behavior on different spectrum. Not everybody wants to change, and we got to be okay with it.
Yeah.
There's some people who really do. They just don't know how.
Yeah. I know for a fact, since I started playing men's hockey, some call it beer league hockey, it's a little different the next day when I have an 11:30 p.m. game start versus an 8:30 p.m. game start. And I know that, the 11:30 game, when that starts there, it's not over till midnight. I get home from the rink at 1. I'm awake until 3.
Yeah.
That next day is not easy.
Yeah.
And you don't have to convince me otherwise.
Yeah.
It's
and
not
I'm sure when you were doing radio too, I mean, like I know some of these people in the morning shows start like 5 in the morning, and
correct.
I'm hearing some of them talk, like, I've got to go to bed super early, and then they have sports folks who are football late at night, and then they're turning around for a morning. Yeah, like time zone.
My morning guy, I did morning radio for 2 weeks, and like that's where people would aspire to.
Yeah.
And I knew then as a 28-year-old, I'm like, this isn't going to work.
Yeah.
My morning guy could be on the air till 10, leave at 11 or noon, go to sleep for a few hours, wake up, go to a show or go to an event, go back to sleep. And my brain did not brain.
Yeah.
I was like, I need to go to sleep when it's dark for 6, 7, 8 hours in a row, or I do not. I was a jerk. I had no temper. I had no creative ability.
Yeah.
And I just looked at him and was like, I know I should want this career-wise, more money, more whatever.
Yeah.
I don't want it because I'm a jerk and I hate myself.
Yeah.
But knowing that is important.
Yeah, totally.
Let's see. We'll go back to competency-based education. When I first heard it, I didn't really understand it. I was listening. It sounded like a buzzword. But what does it actually look like when a fellowship implements it?
Yeah, so I think we really don't know because we're not really doing it per like the specifics. We don't really even have competencies and domains and entrustable activities quite defined yet. That's what's actually happening now. AOMPT has a number of initiatives to try to define what does it look like. So the benefit number one of doing this type of thing is we're actually defining what a fellow looks like, or at least a graduate of a fellowship looks like. Right now we kind of have standards, obviously. We have accreditation standards, which give us direction, but competencies actually say what behaviors, what are the things that they should be doing. If I see this, then I know that's a fellow. So number one, it defines very explicitly what a fellow does. And, residency in orthopedics, they've done that. So we have a little bit of work now to say, okay, this is what a resident's expected to do behaviorally. What is a fellow to do beyond that, or to expand on that? Because it's not always different. The depth of that may change. So that's one definition. Number two, I think the interesting piece is there, as I mentioned before, I think there's a pacing in fellowship, meaning that people come in with different skill sets because of their residency training, because of their con ed training, and some of those skills overlap with what we're already going to teach them. So why do we have to reteach people knowledge that they may have when they could just demonstrate those things that are defined and agreed upon and allow them to maybe go through a program quicker? On the flip side, why do we have to maybe hold people to a very, finite time to get through? And some people may need longer time. When I went through fellowship, I needed 3 freaking years. I came in early in my career, and I was just trying to figure it all out. And so I needed more time. I needed more reps. However, there's some people coming into our fellowship, they've been practicing for over 20 years. They've gotten reps in, and yes, they can refine, but let's let them demonstrate what they already know and then meet them where they are so that they can get through effectively. So that's, I kind of think, if I put my visionary hat on, like, that's the direction we can and should go. And it allows people flexibility. It allows financial, means to not have to pay for all of this stuff that
at once.
And I think, I've challenged program directors here. We need to ask why we're doing certain things. And accreditation is important, but I also think sometimes we get in our way with these, bureaucratic administrative overloads of forms and papers. And why do we have to do this many mentor hours? Why do we have to do this many lab hours? Is it just because somebody had an idea and said, this sounds about right? We have no evidence to really show that it truly is effective for what we're doing.
Yeah.
It's just all motion-based.
Okay. You've been involved in international consensus around OMPT milestones, talking about things that we have can look back on. What changes do you think will define the next generation of fellowship education? So looking back to look forward.
Yeah, I think, it really actually goes back to the updated definition or the modern definition of what OMPT is. And I think what a lot of people get mixed up on is that they think OMPT is a manual technique. It is not. It is using manual techniques within a reasoning model, put simply. But I think if we look to the future and we really understand a long-term mindset, advanced training, use of exercise, behavior change, I think we can really look at person-centered care more appropriately with using not just manual techniques, but everything else at our disposal that the evidence supports. An OMPT practitioner could very well not use any manual therapy at all for certain patients. I mean, that happens in my clinical practice frequently. There's some people where I don't use it. And Dan Rohn, who is, very involved in AOMPT, once was teaching me, and he said, it's more important actually to know when not to use manual therapy than when to use it. And that's always stuck with me because our bias is to say we're going to use manual techniques because we've worked hard on it. I think if we look the vision of things and if our competencies look right, then I think it moves beyond just skill set of a manual technique. We need to be just as precise with our exercise, our communication, our safety, our comfort. All that stuff is beyond just the hands-on thing. And I think that's where we need to focus our attention going.
Talking about education styles or structures, hybrid learning, I think it's safe to say, is here to stay, or some way, shape, or form.
Yep.
What have you learned about teaching hands-on skills from afar that surprised you?
Yeah, I think the main thing is, you can start to prep the person for the work to learn a skill set, before you're in person. I don't think that asynchronous or online-based hands-on skill set for manual techniques, for example, is the right way to do that only. I think there needs to be in-person, but hybrid by nature is both, right? And so in our fellowship, we have people watching videos, practicing and demonstrating, like recording themselves doing it before they come to the lab. And then now we kind of know as an educator, okay, so-and-so's doing this really well. This they need a little bit of tweaking on. So going into it, I kind of know where that learner needs maybe some adjustments and reinforcement, and they do too. And so they can come in a little bit with knowing where they need to focus their attention. So I think that's been nice instead of just, hey, everybody shows up at the lab and it's like, the first half of the day you're just trying to figure out what you do and don't know.
Yeah, love that. Your published work on the person-centered hypothesis reframes reasoning itself. How does that model help clinicians move from fixing pain to partnering for change?
Yeah, and I think it touches base again on looking at the person and understanding that there's, a lived experience in people with pain. We call them influencing factors, so that could be financial issues, that could be stress, that could be lifestyle behaviors, but it could also be positive expectations. Man, I love when somebody comes in and they're like, so-and-so said this come to you, I heard you're great. There's other people who are like, I think PT sucks. I'm only here because my physician told me to be here. Those influence the overall outcomes at some point. So we really looked at that, and then, looking beyond just the pathoanatomy. When I was going through mentorship, years ago, it was like, all right, you step out with your mentor, you'd be like, what do you think's going on, right? And you'd be like, oh, it's a labral tear, the hip or whatever. And we are so quick to like look at physicians and we're like, oh, don't use imaging. And, we need to move beyond pathoanatomy. And when you're like coming up with your hypotheses, what are we doing? We're using the same damn words, So yes, we got to be respective of pathology because pathology yields patterns, and we recognize patterns because patterns elicit behaviors, and those behaviors are usually like, oh, I got to say this or do this or use this intervention. So we need to respect it, but we shouldn't be using a hypothesis that is solely pathoanatomic based. We need to look at pain phenotypes. We need to look at other conditions that might be going on in conjunction. I'm thinking like the schneck, where you have a shoulder and neck instead of just one or the other. They can happen together, and then influencing factors.
First time I've ever heard schneck.
Oh, yeah. Tom Adderley, shout out. He's our faculty member. That is
I'm going to be
trademark.
using that a lot.
Yeah, that's funny.
Yeah. Last thing we do on episodes, you've been on before, is parting shot, which is an idea or quote that you'd want to leave with the audience as we wrap up.
Yeah, embrace failure. It happens to us all. I learned from it many times. I used to be avoidant of it, but man, some of my failures are my greatest learning opportunities. So embrace it.
Love it. Mark, appreciate you stopping by the show.
Thanks for having me.
Thanks for listening to Hands On, Hands Off, the official podcast of AOMPT. Subscribe now so you never miss an episode, and connect with us at aompt.org or at AOMPT on social. Opinions are those of the guests and not official AOMPT policy. See you next time.